Afternoon, everyone. Today's Survive and Thrive talk will include a presentation titled Preventative Care and Health Maintenance for Individuals with a History of Cancer. My name is Kayla Giannetti. I'm a nurse practitioner at the Cleveland Clinic. I work in the Taussig Cancer Institute for the Department of Blood and Marrow Transplant and Cellular Therapy. Today's objectives include reviewing significance by looking at progress and work needed in cancer care, a discussion on risk factors for cancer and secondary cancers, as well as potential long-term and late effects associated with chemotherapy, radiation, and other treatments. We will review important routine health maintenance exam, as well as key monitoring, lab work, diagnostics, essential for health maintenance and preventative care. Finally, we will discuss preventative care measures and important cancer screening assessments. To start, I have two questions right here on this slide, and I think these questions really do help us understand the significance of this presentation. My first question is, what progress have we made in cancer care thus far? And my second question is, what work is still needed in cancer care? We will review these questions in the next couple of slides. In terms of progress in cancer care, according to the American Cancer Society, overall mortality, our mortality rate has decreased by 34%, which is an equivalent of about 4.5 million people, a reduction of 4.5 million deaths of people. This statistic encompasses the time period between 1991 and 2022. And we attribute that this improvement has occurred due to reduced smoking, better screening, and improved treatments for cancer. On January 1st of 2022, it was recorded that there are more than 18 million Americans living with a history of invasive cancer. Most of these people have been diagnosed many years ago. 5-year relative survival rate for all cancers combined is 69% for people diagnosed between the years of 2014 and 2020. Obviously, this is all great news. However, cancer does remain a leading cause of death, and there's still a whole lot of work to be done. This work is including a number of statistics that I will review quickly, including cancer still being the second leading cause of death in the US, only behind heart disease, which was the #1 leading cause of death in the United States. According to the NIH and American Cancer Society, there are over 2 million new cancer cases and approximately 618,120 deaths in 2025 as a result of cancer. Lung cancer is the leading cause of deaths caused by cancer, followed by colorectal and pancreatic cancers. Overall, as suggested in the slide before this, mortality is declining. However, the incidence is rising among women and younger adults. Incidence in women is up 23% since 1978. More women aged 50 to 64 are being diagnosed with cancer, which is a change in historical trends. Colorectal cancer is becoming more and more increasingly diagnosed in younger people. We continue to have persistent, significant disparities in Native Americans and Black populations, and they often experience higher mortality rates. Not including non-melanoma skin cancers, at least 40% of newly diagnosed cancers in the United States for adults are potentially avoidable. And we will also talk about these avoidable things in the next coming slides. The American Cancer Society projects that there will be 2.1 million new cancer cases in the year of 2026, so this year. It's estimated that 626,140 people will die in 2026 because of cancer. To put that a little in perspective, that's about an average of 1,700 people per day, which is just unacceptable. Risk factors include some modifiable and non-modifiable factors for cancer as well as secondary cancers. We'll discuss these coming on this next few slides. Risk factors include things like tobacco use, and we know that this is responsible for at least 30% of cancer deaths in the United States. Tobacco increases risk for lung, throat, mouth, esophagus, bladder, kidney, stomach, pancreatic, cervical, and acute myeloid leukemias. We know that as we get older, our risk of getting cancer increases. Most cancers are diagnosed in people over 65. In terms of diet and weight, colorectal and breast cancers are linked to a high body weight. Things like low fruit and vegetable intake also increases risk for cancer, and high consumption of processed meats is associated with certain types of cancers. About 5.6% of cancer cases, including mouth, liver, and breast cancers, can be linked to alcohol consumption. Radiation exposure includes UV exposure from the sun or tanning beds, and these are associated with skin cancers. Ionizing radiation, for example, radon and X-rays, increases your general risk for cancer. There are certain types of infections, including viruses and bacteria, that increase risk for cancer. These include things like HPV, hepatitis B and C, Epstein-Barr virus, which is the virus associated with mono, and H. pylori. These infections increase your risk because there is some chronic inflammation and damage that can occur to the DNA as a result of these infections. Certain genetic factors, like inherited gene mutations, like the BRCA1 and BRCA2 mutations, can be associated with 5 to 10% of cancers. Some environmental and occupational exposure includes things like asbestos, chemical and pollutants in the workplace, such as some workplaces that involve mining, manufacturing, and farming, can be associated with a higher risk of cancer. These are some risk factors for secondary cancers. 1 in 6 cancer cases is actually a second cancer diagnosis. People with a history of cancer have a higher risk of developing a new, different primary cancer, also called a second cancer. Compared to just the general population, they have a higher risk. Other risk factors for secondary cancers vary and can be based on initial cancer type, prior treatments, including radiation or chemotherapy. These are some of the leading causes of secondary cancers. Age at the time of first cancer diagnosis. Survivors of childhood cancer have a higher risk of secondary cancer. As mentioned before, things like BRCA1 and 2 mutation and other genetic and family history, things such as Lynch syndrome, significantly increases your risk for secondary cancer. Some lifestyle behaviors, these are some of these modifiable behaviors that can be associated with your risk of a secondary cancer, include smoking, poor diet, alcohol consumption, sun exposure. There's something called field effect, and this involves the tissues that are surrounding and near that first tumor that was treated. Some molecular abnormalities can occur as a result of treatment of that first tumor. These molecular abnormalities can occur in the tissues just kind of surrounding, really close to that first tumor, and be altered and be at higher risk for changing into these cancer cells. Other risk factors include things like targeted therapy, immunotherapies, hormone therapies, and immunosuppression. This is just a list of some of the secondary cancers we can see. Leukemia and myelodysplastic syndromes are often related to chemotherapy and typically appear within 5 to 10 years after that chemotherapy exposure. So this means the person had chemotherapy for different types of cancer, and that chemotherapy 5 to 10 years later is associated with a secondary cancer, leukemia or myelodysplastic syndrome. Some solid tumors are often related to prior exposure to radiation therapy. These include breast cancer, lung cancer, and thyroid cancers. Certain immunomodulators are found to increase risk of leukemia, MDS, and solid tumors. We also see certain types of targeted therapies and immunosuppression associated with higher risk of squamous cell carcinoma, and this can occur in the mouth and throat, skin, and genital area. There are some ongoing studies regarding possible higher rates of second cancer associated with prior treatment with CAR T-cell therapy. I will say that more recently, research does not support that there is a higher risk of second cancers associated with the CAR T-cell therapies. However, data continues to be collected, and really time will tell, as this is a newer type of therapy that we have to offer our patients. Some of the long-term and late effects of treatment include treatments such as chemotherapy, radiation, and other kinds of treatment for cancers, and we'll discuss each one of these. Starting with chemotherapy-related effects, we can see peripheral neuropathy, and if that occurs, it typically will continue to improve up to 2 years out from that exposure to the chemotherapy. If it develops months to years out from that treatment or worsens over time, it is recommended to look at some other contributing causes that could be causing or contributing to peripheral neuropathy. For example, certain vitamin deficiencies, diabetes, and these kind of other conditions can cause peripheral neuropathy as well. So we should consider if these things are going on. Cardiomyopathy is a weakening and damaging to the heart muscle. And while this is uncommon of an effect to happen, it can occur months to years out from certain types of treatment, including doxorubicin, cyclophosphamide, and other anthracycline-based treatments. Some symptoms of cardiomyopathy include persistent generalized swelling, cough, or increased shortness of breath, particularly when laying down. Rarely, we can see other blood disorders in cancers like leukemia and myelodysplastic syndrome lymphoma because of prior exposure to chemotherapy. Again, there are some chemotherapies that we see this happen more commonly with, including alkaline agents, also tomerase 2 inhibitors are leading causes of these secondary cancers. Symptoms of blood disorder or cancers that are going on include unexplained bruising, bleeding, significant increased fatigue, or unexplained fevers or night sweats. Radiation-related effects include radiation-induced pneumonitis and pulmonary fibrosis. Pneumonitis is an inflammation of the lung tissue, and fibrosis is a stiffening, loss of elasticity of that lung tissue. This can occur years after radiation has been given and accompanied by a cough. Even in the absence of cough, sometimes we see these lung changes on imaging, for example, chest x-ray or a CT chest scan, and you may not be having those imaging for symptoms that are related to your cancer history. Maybe you have a chest x-ray because you are having something else going on in respiratory wise, and they want to see if you have an infection. Female patients exposed to chest radiation or total body radiation can be at an increased risk for breast cancer. And then second cancers can be associated with radiation, and these include things like skin, oral, thyroid cancers, and leukemia. Some other treatment-related effects include organ damage. We know that high-dose chemotherapy and radiation can cause harm to our organs that are vital to us, including our liver, kidneys, lungs, and heart. And just this long-term can cause potential long-term dysfunction to these symptoms. So things like chronic kidney disease or liver disease can happen. Immunotherapy can also cause harm to organs, so that's something to think about. In terms of our thyroid, we can see thyroid dysfunction, and that can occur after radiation or chemotherapy, and actually as well as immunotherapy. Some symptoms of thyroid dysfunction can include things like weight loss, weight gain, difficulty sleeping, sleeping too much, anxiety, and depression. We can see bone loss occur, such as osteopenia or osteoporosis, as well as something called avascular necrosis occur after use of systemic steroids. And we know that systemic steroids are often a part of some of our cancer therapies, regimens, and it's also used to treat side effects of these different chemotherapies and radiation and other immunotherapy related effects. We use the steroids to treat those side effects. Diabetes can occur as a result of systemic steroid use, as well as due to complications associated with immunotherapy. Some symptoms of diabetes include excessive thirst or hunger, increased urine output, peripheral neuropathy, blurred vision, fatigue, dry eyes, and dry mouth. Blood clots can also occur, and some of the symptoms of blood clots include new or unexplained swelling, redness, or pain, particularly in the lower extremities. In terms of cardiac effects, we can see an increased risk of high blood pressure, issues with your cholesterol and other lipid metabolism disorders, as well as metabolic syndrome. We can see changes in the mucous membrane, skin, and fascia. Things like cataracts, dry eyes, dry mouth, vaginal wall tightening, and muscle weakness are associated with systemic steroid use. We also can see chronic skin changes such as dry eyes and vision. Chronic skin changes, dry eyes, and vision changes can also occur as a result of immunotherapy. Increased risk of infections, including cytomegalovirus and shingles, are associated with immunodeficiency and immunosuppression. Hormone imbalances can be a result of chemotherapy that disrupts ovarian function and significantly lowers estrogen and progesterone levels, often leading to symptoms similar to menopause in women. These symptoms can include things like hot flashes, mood swings, vaginal dryness, and irregular periods. Although less common, men undergoing chemotherapy can also experience changes in their hormones for their testosterone level. And these can lead to symptoms like fatigue, decreased libido, and mood swings. We see deconditioning occur as a side effect of treatment and treatment-related complications. This can impact your overall physical health and strength. We also see cognitive changes. Many patients experience what they describe as brain fog and memory trouble after treatment. These cognitive changes may or may not be associated with other mental health symptoms such as depression, anxiety, and PTSD. This part of our talk will talk about some preventative care and health maintenance. Obviously, we don't want these things to happen to us, so we need to empower you with education on how to be as preventative and proactive as possible. Some preventative care and health maintenance include things like routine health maintenance exams, monitoring lab work and diagnostics, heart health, bone health, endocrine health, and other preventative health measures, and cancer screening assessments. These are some routine health exams that are recommended. Annually, we often recommend a skin exam, but not for everybody. Primary care should be annual. An eye exam should also be annual. It says dilated. I will say there is some new technology now that not everyone has to get their eyes dilated for a full eye exam. We do have this special kind of imaging where dilation is not needed anymore in the eye doctor's office, as long as they're looking for things like cataracts, glaucoma, your retinal health, those kind of things. And it's really a full eye exam and not just what, like getting your new prescription for your glasses, what looks more clear kind of exam, then that is an acceptable eye exam. For women, GYN exam annually, oral exam by a dentist every 6 months. And other helpful collaborators include people in endocrinology, cardiology, rheumatology, and many others. As a caveat, a disclosure to this slide, I do want to say sometimes these exams are needed more often. For example, if you have a history of skin cancer or a higher risk of skin cancer, you may have skin exams by dermatology more often than once a year. This page just looks at some monitoring, lab work, and diagnostics that are important. Routine blood work can include things like your complete blood count, metabolic panel, and your liver function test. Some of these endocrine rheumatology kind of lab work include things like TSH to check your thyroid function, A1C is a diabetes marker, lipid panel, check your cholesterol levels, your vitamin D level, some hormone labs may be indicated. Monitoring your blood pressure is very important, as well as your ASCVD risk. What an ASCVD risk is an atherosclerotic cardiovascular disease risk. This was developed by the American College of Cardiology and the American Heart Association, and it helps determine risk for dying of a heart attack or stroke, and helps us determine if a statin or other treatment is indicated to reduce that risk. Mammograms for women and PAP and HPV testing for women are some monitoring diagnostics that are important. Prostate screening is important for men. It says plus or minus digital rectal exam. Digital rectal exams have fallen out of favor, so the majority of providers will do a prostate screening with a blood test only. Colon cancer screening includes things like colonoscopy or other acceptable alternatives such as Cologuard. Bone densities helps us keep track of our bone health. CT tests are indicated for some individuals. Pulmonary function tests are indicated for some certain individual populations. And then cognitive and mental health assessments. In terms of heart health, lifestyle modifications include 150 minutes of cardio exercise per week. So that's about 30 minutes a day, 5 days a week. If you're not exercising at all, that's not going to happen overnight. I always tell people, start out with doing 10 minutes, 3 days a week. And then after a couple of weeks, increase it to 15 minutes, and then increase it to 5 days a week, and then increase you to 20 minutes until you're up to that 30 minutes 5 days a week. You don't have to do all 30 minutes at the same time either. You can do 15 minutes in the morning and 15 minutes in the afternoon. The Mediterranean diet is very heart healthy. Management of your lipids, as well as that ASCVD risk that we just discussed, can include things like statins and other cholesterol lowering agents. It's important to manage your blood pressure. Some interventions may include a low salt diet and blood pressure medications. Management of your blood sugar can look like a low sugar and carb diet. Sometimes people need oral anti-diabetics, insulin, and other injectables for treatment of diabetes. These things are typically managed by your primary care, although there are some cardiology specialists that may be involved in your care. Some of these cardiologist specialists include things like preventative cardiology, oncocardiology, electrophysiology, and the heart failure cardiology team. In terms of bone health, the recommendation for vitamin D intake is 2,000 units per day of vitamin D supplementation. I will say that some people require more vitamin D if they're deficient. And to tell if you're deficient, that would be a blood test. The recommendation for calcium intake is between 1,200 and 1,500 milligrams per day through your diet and or supplementation. Typically, people get enough calcium in their diet to kind of be able to tell that. You just look at your labels for 2 or 3 days, over a 2 to 3 days time period, and see how much you're getting in. I don't actually get enough calcium in my diet. I only get about 600 milligrams of calcium in my diet. So I take a 600 milligram over-the-counter supplement of calcium, and that's how I get my 1,200 milligrams per day. Weight-bearing exercise such as walking and hiking, essentially anything that your heel strikes the ground, helps build and maintain your bone health. Treatment for bone health include things like bone strengtheners, hormone replacement therapy, and testosterone replacement if indicated. Not everybody needs this treatment. It just kind of depends on what your bone density shows and what your other risk factors are for your bone mass and fractures. This is often managed by your primary care, but some specialists that could be involved in your care include rheumatology, endocrinology, GYN, and urology. In terms of endocrine health, we already discussed management of blood sugar and bone health on previous slides. Treatment of thyroid and hormone dysfunction is also important. This is often managed by your primary care, but sometimes does require some collaboration with endocrinology and or rheumatology. These are kind of in an other category. They don't really fit in the other slides and subjects of preventative care, but are just important different subjects of preventative care. In terms of cognitive and mental health, we often see cognitive screenings that can range from simple to very complex. Mental health and screenings include things like depression and anxiety screening questionnaires. People typically will see these, even sent to them electronically prior to their primary care visit. Sometimes you get a questionnaire while you're in the waiting room to fill out while you're waiting to see your provider. We see that often in the primary care setting. Some individuals do benefit from further workup and or intervention of cognitive and mental health symptoms. And this can include things like cognitive linguistic therapy, and that's administered by speech therapy, additional testing with our neuropsych team, evaluation by sleep medicine, psychiatry, and sometimes psychotherapy is also helpful. Physical conditioning and strength is an important thing to be proactive about. Some individuals benefit from evaluation from physical health and rehab medicine. We can also see physical therapy be very beneficial for people. Often it is appropriate as an early intervention. Sunscreen and protective clothing is important for prevention of skin cancer. Immunizations are preventative for different bacterial and viral infections. As mentioned before, there are some different infections that increases your risk of cancer, including HPV and hepatitis B and C. And we do have vaccines for hepatitis B and HPV. So you're preventative by doing those vaccines and protecting yourself from those infections. We recommend not smoking, vaping, chewing tobacco, or use of illegal drugs, as these all increase your risk of cancers. Alcohol intake is a little bit individualized, I would say. Generally, we recommend avoidance of alcohol intake while on active cancer treatment, immunosuppression, and some other drugs like blood thinners and antifungals. Generally, if you don't meet these parameters, alcohol moderation is okay, but I always recommend speaking with your healthcare team prior to starting to drink alcohol again after treatment, just to ensure that that's safe for you to do. These are some different cancer screenings. For prostate screening, we do recommend a PSA, which is a blood test by your primary care once a year starting at age 50 for males age 50 or older. They will get that done once a year unless you're African American or have a father or brother who had prostate cancer before the age of 65. And in that case, earlier screening starting at age 45 annually is recommended. For breast health, we recommend mammograms once a year. These can be ordered by your primary care. That starts for women at age 40. If you're a female that has been exposed to whole body radiation or chest radiation, the recommendation is to start mammograms at age 25 years because of your increased risk of breast cancer. Cervical cancer screening includes a yearly pelvic exam by a primary care gynecologist starting about 1 year post-treatment. For most women, PAP and HPV testing is not always done on your yearly annual exam. It kind of depends on how old you are and your other risk factors. While you're getting your pelvic exam, if you're due for your PAP and HPV testing, that would be done at the same time. If there's ever any abnormal findings or concerns, more frequent screening may be recommended by your provider. Skin cancer screening is recommended in certain patient populations. For example, people who have had an allogeneic stem cell transplant, we know that skin cancer is the highest secondary cancer that we see in that patient population, so we recommend an annual skin exam. If they find anything abnormal, again, this could be more often as needed. Colonoscopies every 10 years, starting at age 45, ending at 75 is recommended for colon cancer screening. But as discussed previously, there are some other types of colon cancer screening that can be done, and those are done at different intervals. So like Cologuard, I think is every 3 years. And your primary care would keep track of these for you. So it's important to be seen annually and to stay up to date on your colon cancer screening. If they see a polyp or other abnormal finding, again, they may recommend that you have colon cancer screening sooner than that interval that's recommended for a normal colonoscopy, for example. For people who have a 30-pack year smoking history and currently smoke, or who have quit within the last 15 years, a low-dose CT scan of your chest is recommended for lung cancer screening. And those are for people who are aged 55 to 74 years old and should continue once a year until you have not smoked for at least 15 years, or for 15 years. These guidelines are all based on the NCCN guidelines and are updated as indicated. I always recommend being familiar with the NCCN guidelines. It is publicly viewable online, and this will help you stay the most up to date on your cancer screenings. These are my references. And just to kind of wrap up this talk, I want to take a couple minutes just thanking everybody for watching this talk. I think that this information is very important. You know, as a clinician in the oncology world, you guys did this for a reason. It's not only to survive, but also to thrive. And that's why we do these talks. We want you to have a great quality of life, not only a long life, a great quality of life. And I truly believe doing these health screenings and preventative measures will help you do that. It will help you not only survive, but thrive. Again, thank you so much for your time and have a great afternoon.